Lights. In our body, we have, let me see if I can remember all of them. We have magnesium, we have calcium, we have sodium, we have potassium, we have phosphorus, we have bicarb. 1, 2, 3, 4, 5, 6. Which one am I missing? Chloride. So these are the 7 electrolytes in the body. They create electrical currents. Okay? Now, the electrical current, the electricity generated in the body is present on the surface of the skin. Okay? So to pick up the electrical activity, you have to use electrodes. Electrodes, that's what we use. And then if you pick up that electricity, it travels through a wire and goes to the EKG machine, and then the EKG machine can analyze the electricity. Kind of draws it out. So we have 3 types of EKG equipment that we can use to pick up the electrical current from the skin. We have oscilloscope. Oscilloscope is a bedside monitor. Like if you have gone inside the ICU, you can see that monitor hanging over the patient's bed. Okay? That's the oscilloscope, okay? It doesn't draw out the entire EKG rhythm. It only draws out 2 lines of it, okay? It does like a V2, V5, and then lead 2. So just 2 strips are what you're going to see on the oscilloscope. Okay. Now, the V5 on the chest and lead 2 are very good in monitoring the left ventricle. Now, the left ventricle is very, very important because that's where our cardiac output comes out from. Over 80% of the heart attacks occur on the left side. Anytime somebody had a heart attack, more than likely it's on the left side. So that's why we monitor it. It's very important. So those 2 will monitor the left heart while the patient is in the ICU. Okay? And then we have the electrocardiograph. That's the big EKG machine that you actually have to push to the patient's bedside and then hook up the wires and do it. It takes a picture of the patient's heart from 12 different angles. So it gives you the entire picture from 12 different angles. That's what we call a 12-lead EKG. But all that is really needed to do is 10 electrodes. 10 electrodes, but it takes a picture from 12 different angles. Okay? And then we have heart monitor. Heart monitor is like a portable EKG equipment. The patient can actually go home with it. So anytime a patient has a type of arrhythmias that comes and goes, like now you're not feeling well, you're having atrial fibrillation, you're not feeling well, you go to the doctor and the doctor hooks you up to the EKG machine, but nothing. You are feeling okay now. And the doctor said, well, I don't see anything. And then you go back after a while, maybe you do something that is very strenuous, and then you start feeling bad again. By the time you come back to the doctor, well, it's gone again. So what they do is they let you wear that heart monitor for at least 24 to 48 hours. You go home with it. So anytime you start feeling bad, you write down what time it is. and whatever that you were doing that caused you to start feeling bad. Okay? And then after 48 hours or so, the doctor will download the result, okay, corresponding with your note to find out what is going on, okay? So that's Holter monitor, okay? Usually, electrical current is generated from the upper right quadrant of the right atrium. Okay? In the right atrium, 4 chambers of the heart, about right here. And we call that the AC node. The AC node. Sino-arterial node. Okay, that's where the electrical current originates. And then it kind of flows from the right down towards the left. Okay, so the normal axis of electrical current is from the right down into the left. Okay? You probably say that in your sleep. Honey, down to the left. Honey, down to the left. I'm just kidding. All right, so from the right down into the left. Okay? But there are two things that can cause the normal axis to change. So instead of that electrical current going from the right down into the left, it is going from the right down into the right. That's not normal axis. So if you have hypertrophy, right ventricular hypertrophy, the swelling of the muscle, because now look, the left heart is bigger than the right heart. The left heart is more muscular than the right heart. In fact, if you're holding somebody's heart in your hands, you would be holding almost all of the left heart. But of course, if you were holding somebody's heart in your hands, you got some explanation to do that too. Okay, so what's going to happen now is that you got the right side now swelling. Okay, the right muscle now is bigger than the left heart. So you're going to need more electrical current to depolarize it. So that's why you're going to have changing axis. It starts here and then it's going towards the right instead of going towards the left ventricle. Okay, so we'll call that axis deviation. Axis deviation. Okay? And then the next thing is myocardial infarction, heart attack. Heart attack. Electrical current cannot go to a scar tissue. Infarction means a scar tissue. Okay? It's very bad. That is the last stage of heart attack. Heart attack, doesn't, happen all of a sudden. It's not all of a sudden. The heart wants you a lot. Anytime, what causes heart attack is that you're not getting adequate oxygen, okay, to your heart. So initially, when that begins, you're going to have what we call ischemia, okay? And the heart will warn you, and then you look at your EKG rhythm, you're going to see inverted T waves. Inverted T waves. That's the heart warning you, look, give me more oxygen now. And then after a while, if you still haven't given the patient enough oxygen, the heart goes into myocardial injury. And then you're going to have elevated ST segments. It's still warning you. And then if you still refuse to give it oxygen, then it goes to the last phase of heart attack, which is infarction. We don't want that. So that's how come when somebody is having a heart attack, it's an emergency. Okay, because once the tissues die, you don't get it back. Okay? In cardiovascular medicine, it is said that time is muscle. Time is muscle in cardiovascular medicine. Okay? So myocardial infarction and right ventricular hypertrophy. Okay, so this is the normal direction of electricity, okay, around the heart. It will begin from the SA node right here. Now, the ASA node is said to be the primary pacemaker of the heart. That is a normal place for the electrical current to start. Okay? And then once that electrical current originates from here, it will travel to the AV node. Or let me back up. The ASA node paces the heart at the rate of 60 to 100 beats per minute, or signals per minute. That's normal heart rate, 60 to 100. Okay, so the electrical current now leaves the ASA node and then travel this through these little things here. They are called the internodal pathway. So now they go through the internodal pathway, they make it down to the AV node, anterioventricular node. Now the AV node is the secondary pacemaker of the heart. If something was to go wrong with the ASA node, the AV node will take over pacing the heart. And the AV node paces the heart at a rate of 40 to 60 beats per minute. And then the electricity now in the AV node is temporarily delayed in there. It comes down, then temporarily it is delayed there before it continues down the line. Now, it will go through the bundle of His, right here, this little thing here, and then all of a sudden it will branch to the right and left bundle branches, and then the Purkinje fibers. You know, these things here look like fingers, you know. Now, the Purkinje fibers are the final destination of the electrical current. That's how the ventricles receive the electrical current. Okay? The ventricles must do that so that they can depolarize and contract and pump out the blood that is in them. Okay? However, we do have tertiary pacemaker. What if the ASA node cannot pace, the AV node cannot pace? We have a tertiary pacemaker, but we don't want the tertiary pacemaker to pace. That is your ventricle. The ventricle is a tertiary pacemaker of the heart, but it only paces at the rate of 25 to 40. That's not enough, because the way you get adequate perfusion to organs and tissues is by your blood pressure, the blood pressure being able to circulate and how many times your heart is beating. So in real sense, if you walk into a patient's room and their heart rate is 25, you begin CPR. I know that we don't compress on somebody who has pulse, but it is true that you have to compress them at a rate greater than that 25, because a heart rate of 25 will not provide adequate perfusion to organs and tissues. So basically, you begin CPR. Okay? Any questions about that? The pacemakers of the heart and the direction of electrical current. These are the 4 properties that any cardiac cell or nerve cell possesses. Okay? 4 properties. The first one is automaticity. Automaticity. Now, automaticity is the ability of a cardiac muscle cell or nerve cell to spontaneously generate an impulse. They don't need anything to tell them to do it. For instance, the cells of the ASA node have automaticity. they know to just generate 60 to 100 beats of electrical current per minute. They just do it. Nothing tells them to do it. Brian doesn't have to tell them to do it, right? Ashley doesn't have to tell them to do it. They just do it. Yeah, let's just do it 60 times to 100 times, and then we're happy. Okay? The cells of the AV node also have automaticity. They know if they have to, if the SA node is not working, they know to just generate 40 to 60 beats per minute. And then the cells of the ventricles have automaticity. If they have to, they can generate electrical signals at the rate of 25 to 40. Okay, so that's what that means. The ability of a cardiac cell or nerve cell to spontaneously generate an impulse without external stimulus. Okay? Excitability is the ability of the cell to recognize the presence of electrical current. They get charged up. Okay, charged up. If you're sleeping at night and somebody is trying to come into your house, you're going to jump out from your bed and say, "Who is that?" Right? Kind of like that. Once they get the electrical current, they get charged up. They also call it irritability. They get excited, they get irritated, in the presence of electrical current. And then we have conductivity. Every cardiac muscle cell has the ability to conduct electrical current. In other words, this cell here gets the electrical current, it will pass it on to the next one, that one passes it to the next one, and so forth, and all the cells now will get the electrical current and become excited. Okay? And then contractility is the mechanical property of the heart. Mechanical property of the heart, that's what we call it. That's the end game. That's why we need that electrical current. Once the ventricles receive the electrical current, they will depolarize and contract. And then contraction will send the blood out. On the right side, it will go towards the lungs, and the left side, it will go towards the systemic arteries, through the aorta. Okay? So every cardiac muscle cell has these 4 properties. Now, electrocardiograph, like I said, is the best EKG picture because it takes the picture of the heart from 12 different angles using 10 electrodes only. Okay? So when you say 12-lead EKG, be sure that you are not thinking that what is needed is 12 electrodes, because on the exam they can say, how many electrodes do you need to do electrocardiograph? Okay? And then we have what we call the limb leads, okay, and chest leads. The limb leads are the ones that you place on your leg, okay? Right here, and then one here in your arm, okay, like that. And then you have your chest leads, the ones you place across the chest, okay? Or sometimes they call it the precordial leads. Precordial leads. V1, V2, V3, V4, that kind of stuff. Okay? Have you ever done EKG? Yeah, I'm pretty sure you have. Okay, so lead 1. Okay, I'm not going to go into detail about it. Now, the lead just means the direction of electrical current. Okay, look. Lead 1 is left hand positive, right hand negative. So electrical current is flowing this way. Okay, from left to right. Lead 1. And then lead 2 is that way, left leg positive, left arm negative. It goes like that. So now you see lead 2 goes across the heart because it's this way. That's why it's the most important lead. It sees everything that is going on in the left heart. That's how come in that oscilloscope, one of the rhythms that we look at is lead 2. Okay? So it goes right straight to the heart. That's the best lead overall. So on the exam, if they ask you, a patient just returned from surgery where they had some kind of stuff done to their heart, okay? The patient is now back in the ICU for monitoring. Which of the leads will be the best one, the most important one to monitor? You're going to say lead 2 because it sees everything. Okay, lead 2 is the best lead overall. Okay? And lead 3 is left leg positive and then left arm negative. So this is lead 1, lead 2, and lead 3. It forms a triangle. It forms a triangle right there. What did they call that? They call it, I don't spell that very well. Oven, something like that, triangle. That's what we call it. It's an oven triangle. Okay, forms triangle. Okay? And then we have augmented leads. Augmented leads. Okay? Now, the augmented leads, we have AVR, we have AVR, we have AVR. Those are not really very important. Okay? Some of the waves will be upside down. Okay? In the AVR. Okay? Not important at all. And then let's go over the precordial leads. Okay? Now V1 is on the chest, fourth intercostal space on the right hand side of the sternum. That's your V1. Right across the nipple on the right side. V2 is on the opposite side of that. So those two will monitor your right heart. Those two, V1 and V2 will monitor your right heart. If you take that picture, you look at those two. Now V3 and V4. Now the V4 is fifth intercostal space, mid-clavicular line. So in putting those electrodes, once you put your V1, V2, you skip V3. And then you put your V4, which is fifth intercostal space, mid-clavicular line. And then you put your V3 anywhere between the V2 and the V4. That's the best way to do it, because there's really no landmark for placing the V3. Okay? Now, those two will monitor the ventricular septum. And then the V5 and the V6. Now, V5 you place on the fifth intercostal space, mid-axillary line. Mid-axillary line like that. Okay? No, I said it wrong. V6 is, you're going to skip V5 and place your V6 on the fifth intercostal space, mid-axillary line, and then you place your V5 anywhere between your V4 and your V6. That's the way it should be. So V6 is not very important because it's way down here, right here. But V5 sees the left ventricle very well. Okay? So that's how come in the ICU you have those two strips on that oscilloscope. One of them is V5, the other one is lead 2. Okay? So if they ask you what is the best precordial lead to monitor the ventricle, the left ventricle, you say V5. If they say, well, what is the best lead overall? You say lead 2. Okay? Any questions about that? So this is what I just went over. Okay? You got to know where to place your precordial leads, because respiratory therapists do EKG. So you can get a question that says, well, a respiratory therapist is performing electrocardiograph and the V6 fell off. The therapist will pick it up and put it back where? So then you're going to say, well, fifth intercostal space, mid-axillary line. So you got to know where to place the leads. Any questions about this? So now this is EKG paper right there, okay? It kind of looks like this. You have like you're playing a checker or something. That's what it looks like. Okay? So now what we're going to do here is, if you look at that paper, every fifth box you have makes one large box, like 1, 2, 3, 4, 5. You're going to see a bordered line right there. And so inside the large box, you have 5 small boxes. So what we're going to do is, we're going to take out one small box like that, and that. And before I go further, I'd like to tell you that the speed of the EKG machine drawing the rhythm, the speed like that, like when it's drawing, is 25 millimeters per second. And that is on standard setting. Okay, when it's drawing, 25 milliliters. So, if we took out one box like that, that box vertically, like that, we measure the voltage of electrical current. The voltage vertically. So one small box vertically is 1 millimeter, which is equal to 0.1 millivolt. That just means by how much will the amplitude of the wave rise, like that. The electrical current is what causes the amplitude of the EKG tracing. So, on standard setting then, it means that 10 small boxes vertically would be equal to 1 millivolt, because one small box is 0.1 millivolt. Horizontally, on that small box, we're measuring time. So one small box horizontally is equal to 0.04 second. Okay, 0.04 seconds. And then I've already told you about the last thing there, every fifth box you're going to have a border line. Okay, so that means then that if I took out 5 small boxes here, okay, each of them being 0.04 second, multiplied by 5, I will have 0.2 seconds. 0.2 seconds. So one large box is 0.2 seconds horizontally. Okay? Any questions? Now, when you're doing your EKG, you can get what we call artifacts. That's abnormal tracing, abnormal EKG tracing. A lot of things can cause you to have artifacts in your EKGs. You gotta recognize those. Okay. Poor placement of the electrodes. If you get the electrodes, you gotta be able to push it down so that you can stay on the skin. Okay? I mean, you don't have to have mercy on the patient. So, well, I'm not going to push this really hard because I know it hurts. It doesn't hurt. You just press it down so that it will stay down there. Okay? If he has a good contact with the skin, he will be able to pick up electrical current more effectively. Patient activity. Well, of course, you don't want to be doing your EKG when the patient is drinking coffee or maybe talking on the phone. Yeah, let me do this test. You can go ahead and speak to your father while I'm doing this. You will not get good tracing. Patient activity, they're moving around, they're talking, that will make you have artifact. Hairy chest, okay? Sometimes patients may have to be shaved a little bit to facilitate the attachment of the electrodes. Because if you put it on top of their hair, it probably won't pick up really well. Okay, so sometimes they may shave them just a little bit. Okay? But you tell the patient what you are about to do. So, well, I want to shave this off a little bit so I can attach the electrodes. Okay? And then you can actually be sued for that. And I know that you don't have enough money to pay because you're still a student, right? So you'll be sure to warn your patients. Dry electrodes. Inside those electrodes, you have jelly-like material inside it. It's like jelly. Okay? That is what conducts the electrical current. Okay? So if you have dried electrode, it's dried up. That jelly-like material inside there is dried up. Then it will not transport the electrical current to the EKG machine. Okay? So you watch that. And broken wires. The electrodes pick up the electrical current from the skin and then transports the electrical current through the wires to the EKG machine. So if the wires are broken, well, you got a traffic jam there. It's not going anywhere. So you check on your wires as well. So these things here can cause you to have artifact. Okay, so now let's define the waves now. If the current is coming from the AC node, you're going to get P wave. P wave. Now, P wave is a sign that the atria has depolarized. Like that. So P wave represents on the EKG tracing arterial depolarization. Arterial depolarization. If you don't see your P wave, that's not a sinus beat. If you see your P wave, that's a sinus beat, meaning that it's coming from the SA node. Okay? So after your P wave then, the electrical current comes down. It goes to the AV node and then ends up to the Purkinje fibers. And then we have our Q wave here. Right here. Down here, Q wave. Yeah. Now, when the wave is going up like that, we'll call it positive wave. So P wave is a positive wave. If it's a wave coming down, we'll call it a negative wave. So the Q wave is a negative wave because it's coming down like that. The P wave started going up before it came down. So that's positive, negative wave. Now the Q wave represents the beginning of ventricular depolarization. The beginning of ventricular depolarization. it's not very, very visible on a normal EKG tracing. Your Q wave is there, but it's not always very visible. Okay, but it's there. But when you can definitely see a downward stroke of the Q wave before it goes up, something is wrong. It would mean that you have myocardial infarction because electrical current cannot go through a scar tissue. That's why you're going to see that definite downstroking of the Q wave. But otherwise, on a normal EKG rhythm, it's there, but you can barely see it. You can't see it. Okay? So anytime you see a pronounced Q wave, you say that the patient has myocardial infarction. They have had a heart attack. And then we see the R wave. The R wave, in the R wave, the ventricle is still depolarizing. It's ventricular activity where the ventricle is still depolarizing. Okay? And then we have the S wave there. That is also ventricular depolarization. So it kind of starts with the P wave, continues to the R wave, and then the S wave. Okay? So the QRS complex is what we call it. All of it represents ventricular depolarization, QRS complex. If you don't see it, it means that your ventricles are not depolarizing. And I don't think you should be alive, then you won't be alive, because basically what it means is that you don't have any cardiac outputs. The ventricles have to depolarize and contract and pump out blood. So when we don't see it, you got a code. You have a code, you have critical emergency. That's not good. And then we have the T wave right here. It's a positive wave because it goes up before it comes down. The T wave signals the end of ventricular repolarization. Ventricular repolarization. See, when the masses depolarize, they have to repolarize. So it's like they depolarize, they contract, they pump the blood out, and now they have to repolarize to wait for another electrical current to come down. Okay? It is important for me to mention here that the repolarization of the atria is not seen on EKG rhythm. We don't see it. Okay, but because the repolarization of the atria is taking place when the ventricles are depolarizing. So there's nothing here, no EKG feature that tells us that. But the T wave tells us that the ventricles are repolarizing. Okay? Any questions about that? And then we have the U wave. The U wave is right there. On a normal EKG reading, you can see that. It's not there. Okay? But if you see your U wave on a rhythm, that's a problem. That's abnormality. It means that you have electrolyte imbalance. Electrolyte imbalance is what's going to cause your U wave to show on a normal rhythm. Otherwise, it doesn't show. Okay? Now, what most books say that causes the U wave to show up is when the Purkinje fibers are repolarizing. When the Purkinje fibers are repolarizing, you will see the U wave sometimes. Sometimes you just don't see it. Okay? You won't see it most of the time, not sometimes. Any questions? And then we have what we call the PR interval. PR interval is the period from the beginning of a P wave to the beginning of the QRS complex, if you want to define it that way. From the beginning of the P wave to the beginning of the QRS complex, which will be the beginning of the Q wave. Or you may say from the beginning of a P wave to the end of the P wave. Either way will be fine. Okay? It represents the amount of time that it takes the electrical signal to travel from the AC node down to the ventricles. The PR interval represents the amount of time it takes for the electrical signal to travel from the AC node down to the ventricles. Normal PR interval is 0.12 to 0.2 seconds. That's the amount of time that you should take for that electrical current to travel from the AC node down to the ventricles. If it's more than 0.2 seconds, then we got a problem. That's what we call a block. A block. If your PR interval is greater than 0.2 seconds, you get a block. We're going to talk about that. Any questions about the PR interval? And then we have the ST segment. ST segment right here. This lower area here. See how kind of like on the base of the rhythm here, like here. That's your ST segment. ST segment represents the beginning of ventricular repolarization. The beginning of ventricular repolarization. It is a very important feature as far as interpreting EKG is concerned. If somebody is having chest pain or getting ready to have heart attack, once we hook them up to the EKG machine, we look at the ST segment. Because if that ST segment, see how low it is? If it's raised up, that's called ST segment elevation. That would mean that the patient is having a heart attack. So it's very, very important. And then we've already talked about the QRS complex. Now, the isoelectric line, this is not well drawn, it's supposed to be a line. The isoelectric line is a line from which all the waves rise and fall. So it's supposed to be like this, on the same line, really. See, they're supposed to be on a level here. Is a line from which all the waves rise and fall. We can use it to define a wave that is spiked, very tall, or a wave that is depressed. So when the wave is very close to the isoelectric line, let's say that this is my P wave and this is what I got. Very close to the line, then the way I'm going to define that P wave is that the P wave is depressed. It is depressed because it's very close to the line. If my P wave is way above the isoelectric line, I can say that the P wave is spiked or too tall. Okay, so that's what we use the isoelectric line for. Okay? Any questions about the isoelectric line? Okay, so right here, this here tells you how you can calculate your heart rate, which is very important on the exam. How do you calculate your heart rate? Because they're going to show you a picture, and then they say, well, what's the heart rate here? Okay? So now, when the EKG, I think they call that in the photograph, is drawing like this. Okay? It will travel 1,500 small blocks. That is 1, 2, 3, 4, 5, 6 into 1,500. It will travel 1,500 small blocks in 1 minute. Okay? The speed is going. So what we can do then in calculating our heart rate, if I want to calculate my ventricular rate, so what I have to do then is I have to take 2 consecutive QRS complexes, because anytime you see the QRS complexes, it means that the ventricle, you've had a heartbeat. The ventricle contracted. So if I count the number of small blocks between the 2 consecutive QRS complexes, okay, I will divide 1,500 by that. Let's say if I counted 30 small boxes between 2 consecutive QRS complexes, I'll divide 1,500 by 30, that will give me 150. My heart rate is 150. If I counted, let's say 15, if I counted 15 small boxes, okay, then I'm going to divide 15 I'm going to divide 1,500 by 15, and then my heart rate is 100. Okay? Now the first one I made a mistake. My heart rate there should have been 50. 1,500 divided by 30 would be 50. I think so. Yeah, 50. Okay, so if I have 15 boxes, then my heart rate will be 100. Okay? Any questions about that? That's how you calculate your ventricular rate. Now, if I want to calculate my arterial rate, because sometimes your arterial rate will be different from your ventricular rate. Okay. It's supposed to be that if your heart is working normally, if your ACA node discharges 60 electrical signals, all of them will make it through the AV node and come down to the ventricles. So under normal conditions, the arterial rate should be equal to ventricular rate if you don't have any problems. But we have some arrhythmias that can cause the arterial rate to be different from the ventricular rate. For instance, atrial fibrillation, or maybe atrial flutter. Okay? But now, if you want to calculate your arterial rate, then what you're going to have to do is you count the number of small boxes between 2 consecutive P waves. Okay? If you got 30 small boxes between 2 consecutive P waves, then it means that your arterial rate will be 50. Are you following me? Please speak up, or forever hold your peace, right? Is that the way they say it? Yeah. All right, so let me say this one more time. If you want to calculate your ventricular rate, one way that you can do it is you count, because that 1,500 comes from the number of small blocks the thing covers in 1 minute. So we get the number of small blocks between 2 consecutive QRS complexes. We divide it into 1,500. That's your ventricular rate. If you want to calculate your arterial rate, you count the number of small boxes between 2 consecutive P waves. and divide it into 1500. Okay, that's one way to do the heart rate. The next way to do it is you can count the number of large boxes. Like I said before now, in a large box you have 5 small boxes. And this will be a large box here. 1, 2, 3, 4, 5. This is another large box. So now, when the EKG thing is drawing, it will cover like 300 large boxes in 1 minute. Like that. 300 large boxes in 1 minute. So now, if I counted 2 large boxes between 2 consecutive QRS complexes, then my heart rate will be 150. Because I'm going to divide 300 by 2. If I counted 3 large boxes between 2 consecutive QRS complexes, my heart rate will be 100. See that? Very easy. Or if I want to count my arterial rate, then I can count the number of large boxes between 2 consecutive P waves. And then I'll divide it into 300. Okay? So we got 2 ways that you can do your heart rate. The next way to do it is you can count the number of QRS complexes in a 6-second strip. Usually they print it out in 6-second strips, you know, like that. Give you that piece of paper like that. That's 6 seconds. You count the number of QRS complexes, you multiply it by 10. And that will give you your heart rate. Now this one here works. This one here doesn't work on a rhythm that is irregular. Now this is irregular rhythm. An irregular rhythm is where the QRS complexes are not equally spaced out. In other words, your heartbeats are not coming at a specified interval. Okay, so it's going to be like this. That's your P wave, then you have your P wave, QRS complex P wave, and then here's your P wave, QRS complex P wave. This will be an irregular rhythm. Because you know, you see from here to here is greater than from here to here. And this is even greater than this. So your heartbeats are not coming at the specified intervals. Now, if I want to, let me see, what did I just say? Yeah. So if you want to check the heart rate on a patient who has irregular rhythm, it's best to use the third method, the third one. Okay, but now, if you use these 2 here, the first 2 there, it wouldn't work. Because if I'm counting the number of small boxes or large boxes, well, I have more here than I will have here. I will have more here than I have here. So it doesn't work. Your heart rate will not be precise. Okay, so irregular rhythm, count the number of QRS complexes in a 6-second strip and then multiply by 10. It works better. If you want to figure out your arterial rate and the heart rate is irregular, you count the number of P waves in 6-second strip and multiply by 10. Any questions about that? But now, the third method can also work with this one here too. Like if you have somebody that has regular heart rates, you can also count the number of QRS complexes and multiply by 10. That should work. Yeah, so we have rhythms that are regular. Regular just means that the QRS complexes are equally spaced out. Your heartbeats are coming at a specified interval. Irregular means that they are not. And sometimes you have what they call regularly irregular. Okay, regularly irregular. Okay, it's regularly, I know it is irregular, but it's coming regularly. Okay? Regularly, irregular rhythm. Now let's define some terminologies and then I'll give you a break. Short break. Ischemia. Ischemia is deprivation of oxygen to the cardiac tissue. Okay, deprivation of oxygen to the cardiac tissue. The tissues don't have enough oxygen. That's called ischemia. And when you have ischemia, you can see that on EKG rhythm. Your T waves will be inverted. You know, remember we talked about the T wave being a positive wave. So you're going to have inverted T wave like that. It will invert. So when you have an inverted T wave on EKG rhythm, if you don't know what to give, you give oxygen. They need oxygen. That's the problem. We have injury here. Acute damage to the tissue, the cardiac muscle cells. Okay? And then that one, usually you have ST segment elevation. The ST segment will elevate. And then we have infarction. Infarction is the necrosis of the tissue. You have scar tissues. So if you look at it, we have 3 eyes in MI. We have 3 eyes in MI. The first eye is ischemia, where that's where the heart is warning you. If you don't give it enough oxygen, it goes to the second eye, which is injury. And then if you don't give it enough oxygen, then it goes into that last phase of heart attack, which is infarction. So like I said before, anytime somebody is having a heart attack, the emergency there is to prevent them from going to infarction, because once they go to that infarction and there is damage to their tissues, they will never get it back. And from there, moving forward, their cardiac function will deteriorate. Okay, you don't fix that. So some abnormalities in the EKG rhythm, you can have spiked P wave. Spike means that it's very tall. So that isolated line, that's normal P wave. And then if you have one like this, that's very tall. It takes a whole lot of electrical current to get that amplitude up there. You know what's going on? It's because now remember the P wave is for the right side. So now you have a lot of muscle there on the right side. We'll call that right ventricular hypertrophy, swelling of the muscle. So what's going on now is that most of the electrical current coming from the SA node is going down to the right side. That's why you have that amplitude. Okay, so when they show you spiked P wave, you say right ventricular hypertrophy. Okay? That's axis deviation there. You can have significant Q wave. Okay, like I said before, on a normal rhythm, you really don't see your Q wave. It's there, but you really don't see it. But if you can see a definite downward stroke of the Q wave before it goes up, then there is infarction. And the reason it does that is because electrical current will not go to it. That's how we make diagnosis of heart attack. We talked about ST segment elevation. If the ST segment is elevated, then the patient is having myocardial injury, or they're having a heart attack. Okay? You give them plenty of oxygen, you give them plenty of nitroglycerin. Nitroglycerin is a vasodilator. It will vasodilate your blood vessel. Because after all, what causes heart attack is deprivation of oxygen to the heart. So if we can open up the blood vessels, have increased blood flow, oxygenated blood to the myocardium, we'll be doing okay. So that's why we give them nitroglycerin. It's a vasodilator. So inverted T-wave we talked about, that is indicative of ischemia, and then that can also be indicative of hypokalemia, low potassium. What's normal potassium? Let me see if anybody remembers their lab. What's normal potassium? 35 to 45. Okay, yeah, that works. There's something else it's missing. Are you 35 or put a period between them? 3.5 to 4.5.
What is it? I'm sorry.
3.5 to 4.5. Yeah. This is where I remember them. Potassium is 3 of them that you really have to know if they're going to ask you. Potassium, here's your normal ABG here. Right? You just put a dot between them like that. And then sodium. Again, here's your normal ABG. Just put 1 in front of it, 135 to 145. And then your chloride, this next one, is the way that we classify normal oxygenation. 80 to 100 equals normal oxygen, right? So your chloride is between 80 to 105. I remember them that way, okay? All right, so let's keep on going here. Digitalis toxicity. Digitalis, or digoxin, is an inotropic agent. It's a drug that we use to increase myocardial contractility in patients that have CHF. Okay. That drug does not clear from the body very fast. The liver does not process digoxin or digitalis very fast. So accumulation of it in the body can cause toxicity. Okay, so did I teach you advanced pharmacology? Yeah, we should have covered that. So anytime a patient is receiving digoxin, okay, digitalis is a group of drugs that digoxin belongs to. It is a protocol to do a blood work every morning, every AM. The lab must do blood work to check on the level of digoxin in their blood. Because if you don't and the drug accumulates, it causes a lot of problems, including a rebound effect. Now, rebound effect on anything is that you get opposite of what you're looking for. Now, digoxin is meant to increase cardiac output. A rebound effect will be that it will cause a decrease in cardiac output. Okay, so we have to monitor that. It can kill your tissues too. And then we have the spark T-wave. Spark T-wave is hyperkalemia, high potassium. You see a lot of this in patients that have end-stage renal failure. End-stage renal failure. Because their potassium goes through the roof. Potassium goes through the roof if you have hypokalemia. I mean, if you have renal failure. Okay. Now, sometimes the respiratory therapist may be called to go to the dialysis area and administer a breathing treatment with albuterol. Okay, higher dose of albuterol. So instead of the 2.5 milligram, the doctor may order for you to aerosolize 5 milligram or 7 milligram. It's because albuterol helps to decrease potassium. It decreases, it closes the potassium pump. Okay, so anytime you're called to come to the dialysis area or renal department area, wherever, to do a breathing treatment, and then you see that the doctor has written the order for you to give more than normal dose of albuterol. That's why, because albuterol will decrease potassium. Okay. Pure interval, we talked about that. Okay. Now, pure interval is prolonged when the time is greater than 0.2 seconds. And if it is greater than 0.2 seconds, then you have a block. That's what causes heart block. Any questions? We have one more lecture. You want 20 minutes or you want me to go ahead?